if you're always going to be here, I am. Yeah. I don't know if you are, but I'm the lead of this lecture all the time.
Well, yeah, we're here every fortnight or so. Yeah.
Have a good lecture.
You too.
Yep.
Sure. All right.
Is it on?
Can I get your lecture slides, please?
Yep.
All right.
I'm calling 10 people. What do you reckon?
I'm calling 15.
15?
Yeah. All right. How do I? No name? Yeah. No name. Renal. Yeah.
Yeah, Renal.
Which release paper do you want to go through?
Both, if you want.
Okay. I'll have to find it somehow.
How do you get people to come to these things? I don't actually care if people come or not, but as you organising, do you have like, are you supposed to try to get people to come or something? Or?
No, look, what I say is like, it'd be good if you can come, mate, but at the end of the day, people are going to look at the slides and they look at the recording. That's the reason why we do the lecture. Is it's going to get to the students at the end. And the end result is going to be a net benefit to students. And so I think that apart from any of the egos of the lecturers, I think most people are happy with the current arrangements. Yeah. Like there've been a few. There's been some feedback that the turnout hasn't been very good. But personally, I don't.
And they get skills if they turn up, so.
Yeah, mate. What did you want again? The exam?
Yeah.
And to all those at home, I'm sorry that you have to hear my voice and Joash's.
Are they listening?
Yeah.
Oh, cool.
5th and 6th.
Oh, it's only 6 of you. Yep. We get to think the back. I'll probably just look it down. It's not going to be that many people anyway.
Oh my God, where is it? I can't find it. Oh, here we go. Here. Paper 1 and paper 2. There we go.
Alright. You know, bring people inside.
Yeah.
Yep.
There are a couple others. They probably just went to buy food or something.
Oh, that's all. Let's do it.
You can take, you can wait.
Give me a second.
Oh, maybe.
Battery pack, you got a charge, you got a cable it. I don't have no cable.
Wait,
Oh, sorry,
wait, what do you want? You want to charge it for?
She wants to charge it.
Not urgent.
Do you have a charge for that?
I don't
I
have
don't have a table.
I have cable as well though, because my laptop uses the micro cable now. I can use it.
Yeah. Oh, yeah.
Does anyone have a charger? All right.
Oh, do you want your phone?
No, I'm right. Where are you charging it?
The PC will charge fastest. Oh yes. Huh? Yeah, it's charging. That's okay.
did the tap. We're being recorded.
Oh, we did ours is random. We haven't got it.
Yeah, I got quite a bit of time. I'm just not big on my. It is, I understand. You have to do. You have to do. You have to hurdle. You have to pull and there, but hurdle and some. So it's an MCR as well then? Yeah, it's like 5 mini MCRs and but it's pretty tough in terms of
Yeah,
sure. When I do it, monitoring. So it's good, but there are a lot of people from like overseas from backgrounds that don't there, and like, which is fair enough. I get it. So it's just I don't.
It's a lot more like us.
This is way too
It's like, why is it so full?
They went into the next room next door, and they're like, too many people here, not us.
Oh, the chin. Oh, my feet are so red.
What daytime table?
Pouring outside now.
Yeah.
I feel like I just shoveled down here.
So you're looking for now?
Are you only doing for GN? So
No,
you're
I'll flip through the invoice up in the application.
what?
Which you want to do that?
No. I just want to at the beginning.
Yeah, but that's the rest is
I tried.
because I assume he was gonna
Right around 2 hours.
say like.
The nurse was like, you know what, actually, you don't allow. No, it was like,
That's what I'm saying.
Good, Steph.
it was like literally last week, for the last 4 weeks. People have been doing it. She was like, no, you can go ask my sister around. I was like, okay. Like, I literally, I just got permission from the branch on this board.
Yeah.
He has just told you that's why.
Yeah.
He was like, I don't want you to. Alright, bye. No, she was like, Russian.
Oh, really?
Yeah.
Russian lady today since.
I was able to do this.
Kind of different.
Yeah.
He was like, no, I'm literally wrong. I was like, people have been doing it for the past 5 weeks. I know for that. I know it for that. But I just got permission from the branch. These are good patients. Like, no.
I don't think we can say like how to do it. That was rapid fire. Isn't it blue and a tube going down?
And I was like,
Yeah, so Lewis Ronan,
you know, they
used to be really buff, but lost his gains in the past few months. Yes, good lad, good lad. Lewis Ronan.
It took me like 2 weeks to get 2 things.
Did he just intimidate everyone? They're like, hey, do you know that I eat a tub of cottage cheese every day? Yeah, he used to when he had gains, of course. I mean, like, commiserations to him. Lewis, if you're listening, I'm sorry. Yeah. We'll start in 4 or 5.
Yeah. Don't worry about it. We'll be quick.
Jeez.
Hey man, we got it.
I was like,
I I don't mind.
Oh, Rohit, why are you listening to this? He's doing BMS, I reckon. All the time. I saw him on the bus. Took a photo of him. It's pretty stalkery.
Yeah. And then on the computer.
All right, one more minute and then we'll start, everyone.
Does anyone want Skittles?
Skittles.
Skittles?
That's disgusting.
It has chocolate in it. Is there an M&M in there?
No, Skittles do not have
There was chocolate in it.
So.
No.
Oh.
It's not. It was brown. Like I have cavities. That was chocolate. And judge when we like,
What's he doing?
Yeah, they were chocolate. Just weird.
Yeah. I mean, it's a welcome surprise, but if you both have
I'm gonna find her.
Good
on you. Yeah, all of them.
Real Skittle.
There's so more.
I think there's so much sugar in our lives as maybe more.
Yeah, that's what I said. I was like, it's tiny. I didn't want you to
I'll be
tiny.
up and out.
Oh,
yeah, stop it.
I was like, I just did something different. But I get you guacamole.
We're good to go.
It's out here, Sean Paul. Yeah, but if you get the veggie one.
Hi, everyone. I think we'll get started. Cool. Okay, so my name's Josh. We're going to be talking about renal stuff today. I put up this picture for a few reasons. Full disclosure, when I got allocated to this, I put preference renal third, so I don't know how I got it, but I did. I also put this up for a couple other reasons. One, this is kind of my face throughout renal all of last year. I feel like people learnt words and stuff that came along and didn't really know what was going on. So the goal today is just to be getting through some of the core content. Also I reckon this is my face when I heard that one of my friends, Sartak, you may have heard of him, went for like 2.5 hours, I believe. So this is going to be a short lecture. And lastly,
Are you going to compensate for his
his lack of humor, or
No. All right, shots fired.
yeah. Cool. Thanks. I can proceed, Anuj. Thank you. Yeah. And lastly, I guess this is also my face when people at the start of lectures just waste a whole bunch of time talking about random stuff. So I'm going to move on and I'll do that as well. Okay. So the overview for today is this. You can only really get tested in two ways, your INQ and your OSCE. That sounds pretty obvious, but that means what you should do is gear your study towards that. So for renal, what you need is a good knowledge of the core conditions. What do I mean by core conditions? Those are the things in your PBL. You need to know that really well, and then buzzwords for the rest. For the OSCE, it's the same systems review. You don't have to do the cluster questions as much. And your PBL topics, again, are the things they're going to test you on. Technically, there's 3 ways you can get tested, but I'm never touching path again, ever. And you will, after third year, you won't either. So let's move on. So quick review. So general advice, renal's not like pre-clin. You don't have to know about the phys or the pharm or anything like that, or the anatomy. Just the histopath. And there's just, oh, you might be close. There's 12 people. Okay. I might win this bet anyway. And they're just buzzwords. And really, you'll get about 7 questions on renal. And 4 or 5 of them will be GN based. So we're going to be covering that mainly today, and you can just read the rest. And for people at home, I guess you're going to do that anyway. Cool. So how to think. Now you might have seen this before as a way of explaining how to think about renal problems. I think it's useful in terms of thinking about the differentials, but that's about it. It doesn't really help you with your clinical thinking. So pre-renal is in things coming into the kidney. So things that reduce your flow like shock, renovascular disease, and then you got intrarenal problems like damage to the kidney itself, and then afterwards like a stone or an obstruction from prostate cancer or something like that. So those are some ways you can think about renal, but really it's just down to knowing the condition. So these are the 4 major conditions that you need to know. Let's just quickly go through them. So in every system, you have an acute and a chronic disease. So like you could think of like heart disease, the acute's AMI, the chronic's the chronic heart failure. Acute for rest was asthma, and COPD is the chronic. And so you need to know like the acute and the chronic one. But for renal, you don't really need to. Like you don't really get tested on it. Now in terms of AKI, or also known as acute renal failure, this is the definition for it. So these are 3 things that need to change: a decreased GFR, increased creatinine and urea. And you can get a whole bunch of symptoms, etc. You can read them at home. Again, you can think of it as pre-renal, intrarenal, post-renal. Now, I'm going to skip most of this stuff because I think you can read at home. Just a quick note, triple whammy, I'm sure you all know about that anyway, but it's basically don't give those drugs in renal disease because it can cause more renal disease. Intrarenal. Now, I want to draw your attention to this because this is important for assessment and stuff like that at the end of the year. There are 2 diseases, the top one, ATN and AIN. Now, sure. The main difference that you need to know is that tubular necrosis is usually caused by ischemia, whilst interstitial is caused by drugs. That's literally the difference that they'll be. By the way, if something is in a different color or bolded, remember it, like when you go home. Also, I understand, I was going to say the start, but a lot of you probably already have pre-existing notes, so I've tried to make it put into the system so you can either add it or to your notes or just card the whole thing. I've got a whole bunch of buzzwords at the end, so don't worry about writing too much down. Okay, renovascular disease. Yeah, key point. So fibromuscular dysplasia is common in young children. So I think it's more of an American question, but what they might ask is what is the most common cause of renovascular disease in a young person? It's fibromuscular dysplasia as opposed to arteriosclerosis, because obviously children will not likely have atherosclerosis. So that's sometimes tested, so just remember that. I know it's not bolded or in a different color, sorry, so I guess you guys get to write it down. HUS, yeah, that's associated with E. coli, and so it's more bacterial, and that's pretty much it. So AKI, yeah, don't worry about it. Post-renal, think about stuff that can cause it, but it's usually not acute. So cool, that's it. This is a rifle criteria. I swear everyone in 3rd year last year knew this, and I didn't, but learn it. Cool, thanks.
Is it important?
Honestly, I don't think it's that important, but if it comes up in an OSCE, you probably want to be able to know it. I'm not entirely sure what its use is beyond stratifying some risk. Yes, sorry. Yeah, so I mean, I don't know what. I guess when you get to hospitals, patients do want to know their prognosis. Like that's a pretty important question to be able to answer, but I wouldn't commit too much memory towards it. Okay, management. You address the problem and you just change the volume. I've got the correction of hyperkalemia, which you should know. I'm not sure if you have an electrolyte lecture or someone giving you. You do? Okay, cool. Yeah, that guy will go over it. Awesome. Renal failure. Now, you've already learned about this in 2nd year, chronic kidney disease, chronic renal failure. You remember this stuff, the different stages. You basically don't need to know it anymore. I mean, all they ask you on is the causes of chronic kidney disease, and the big ones are diabetic nephropathy and GN. Polycystic kidney disease really gets tested on buzzwords, and I guess hypertensive stuff is also tested, but this is the main part of renal. This is what they'll test you on, so we're going to spend time on that. Cool, skipping it. You might remember from 2nd year these slides about how the renal stuff will affect different systems like your anemia and your calcium pathways, and so know that if this is for OSCE stuff, but otherwise for EMQ won't be tested. Cool, GN. I'm actually going to skip this so we can come back to it at the end. So, Cool. All right. Benign prostatic hyperplasia and prostatic cancer. Huge obscure topic. You'll notice that this thing is the only thing in the slide which is red, underlined, italicized, and bold. I'm still a little bit salty from last year's paper, to be honest, but you can take that as you will. This is a really important slide. I think it highlights what you probably want to be asking in OSCE in regards to the urinary system. And so it's a nice way of remembering what you need to be doing. But you should know this from second year already, but just in case you forget. BPH, yep. Yep, there we go. So I guess it's in bold, not different color, but the thing you want to be doing is a TERP. That's how you fix it. And here's bladder cancer and prostate cancer, and some questions you should know the answer to if it comes up in OSCE. Cool. All right, minor conditions. There are 4 minor conditions that I thought were on the matrix that we should talk about. So UTI, kidney stones, dialysis, and polycystic kidney disease. So UTIs, pretty much the same as second year, except in second year you learn a lot about like the causes, and you learned about how it's caused by E. coli, and you 10 to the 5 for the microorganism to be diagnosed. Don't really need that anymore. Also, you might remember, we treated with trimethoprim. We add a few more drugs that we can treat them with now. And so Keflex, just put that one in your mind. And we'll come back to why later. Basically, okay, so this is, with UTIs, there are different types of UTIs. And it's a bit frustrating because sometimes when they ask you the question, they'll put up UTI, pyelonephritis. Like, isn't that kind of the same thing? So you need to be able to distinguish between what they are. So cystitis is lower down. Just in general, as you know, UTIs are more common in females because they have like anatomical reasons, because they have a lower, a shorter urethra. So it's easier for bacteria to get up, basically. Interstitial cystitis, you don't really need to know this, but basically this is not really as much on infection, more on like just having a really big bladder. And so the treatment's not antibiotic related, as you can see. And lastly, pyelonephritis. So basically the difference between UTIs and pyelonephritis is if you have pain in a really high area, that's pyelonephritis. That's the difference. So often it'll be the same history, except it won't have the loin pain or the higher up pain. And that's it. That's all they expect you to know about the difference of it. So, yep, that's it. Kidney stones. Now, with kidney stones, there are 4 types of kidney stones. And basically, all you need to know is the buzzwords for them. So calcium kidney stones, which is the most common. Sometimes they literally will say, has high calcium. Yeah, it's pretty easy. Yeah, it's good. So sometimes they'll test you on whether things are radio-opaque or lucent. So both calcium and struvite are calcium opaque, which means you can see them on an X-ray, and the other ones are not. So they're radiolucent. So with calcium, most common one, high calcium, you can get the answer straight away. With struvite, usually they come after an infection, and they have this thing called a staghorn calculus. You can see there, it's like that thing, which is actually in the pelvis of the kidney. Now down the bottom, they've got a picture of what would look like if you actually took out parts of that kidney stone. Sometimes they'll ask you questions on it, but it's pretty rare. And so it looks like a coffin lid, if you can use your imagination to see what that's like. The last one, so the third one's uric acid. So again, they'll say they have gout or some history of gout or high uric acid. So not very complicated. And lastly, cystine, which is more Pete's thing, where they have like an inherited disorder, where they have cystinuria. And they have hexagonal crystals, so 6-sided crystals. That's basically it. Now, you remember this from second year, the places where kidney stones can lodge, PUJ, VUJ, and pelvic brim. And then there's another one that we've added, which is under vas deferens. With kidney stones, it's imperative, if it's an OSCE, that you make sure that it's not AAA or ectopic pregnancy. So you know that rule that basically all females are pregnant until proven otherwise, and they're all ectopic pregnancies until further proven otherwise. So you just need to make sure that's not the case. And lastly, the investigation. Now, this is a bit frustrating because sometimes they give you a CT, sometimes they give you X-ray KUB, but make sure it's CT KUB. That's the investigation that you use. Sometimes they'll ask you for ultrasound as well. So it's a bit annoying. And I remember we're at Monash Health, and the person who was teaching us basically didn't really have an answer to this question. But if I were you, I'd put CT KUB. And yeah, I think that's the best investigation, but the first line is ultrasound. So sometimes they have a distinction between the best one and the thing that you do first. Cool. Management is just pain relief. If you've ever seen someone in kidney stones, it's really bad. Fun fact, so I'm on women's rotation right now, and apparently we had a lady who came in with kidney stones 3 days before she gave birth, and she said the kidney stones are worse, which is really surprising because usually retrospectively pain's not that bad. So yeah, this is a pretty serious disease, I guess. So yeah, make sure you treat them with pain relief. Cool. Dialysis, no. Polycystic kidney disease, you can read it. You should just read it, like, to be honest. Okay, autosomal dominant. So there's autosomal recessive, but it's more in pediatrics. So autosomal dominant disease, that's important. The reason I'm saying this is renal, there's so little they can test you in renal. They often borrow it from other specialties. Like they'll test you in renal ID or renal room or renal pathology. So sometimes it's hard to study for renal because you can know GN really well, but there'll be 4 out of 7 questions on that sort of stuff. And then the rest will be from other things. And we'll go through some of the faculty release papers, and we're going to get you guys to do it. And then I'm just going to walk you through it. And you understand what I mean by that. So with polycystic kidney disease, I guess the main thing you have to know is associated with something called berry aneurysms. If you see that, you go polycystic kidney disease. Sorry, I thought you were just laughing. Okay. Oh, was it? Okay. Well, I guess you're sorted then. Cool. Management is because, yeah, ACE inhibitors. So you basically want to reduce their blood pressure. As we talked about, you can get aneurysm in the brain, not good. Cool. Oh, with polycystic kidney disease, sometimes the question literally says they have cysts in the kidney. And that's it. Okay, cool. We're almost done. Oh wait, we haven't done GN. Okay. Okay, OSCE. So quickly with the OSCE, if you really want to read slides on OSCEs, I don't know why you'd want to do that, but you can look at last year's renal thing. The guy had a decent renal OSCE thing. The rest was all right, but mainly his OSCE stuff was pretty good. So look at that. System review is exactly the same. Now with your history, sometimes you have to think renal, like endo, is one of those systemic systems. And so you have to actually think about other things, not just the renal things. So you don't just ask the urinary things. You need to think outside the box a bit. So with GN and things like which you're going to get to, and I'm sure you know about it, you can get problems with like ankle edema or like edema higher up, shortness of breath, nosebleeds and stuff. So we'll see that in some rare things with vasculitis. And I know that you might do some practice OSCEs at the end of the year, and one of them is like a ridiculously tough Wegener's or something like that. And so it's a bit unfair for them to do it in OSCE, but it can happen because I don't think they really care too much about fairness. They just want to split the cohort, which makes sense. So cluster questions aren't super relevant. So I know, does anyone, just for people here, who doesn't know what I mean by cluster questions? Everyone knows what that means, right? It's okay to put your hand up. You don't? Oh, that's cool. Okay, so like for example, when you have heart failure, you might ask questions like, do you have shortness of breath when you're sleeping? Do you ever wake up in the middle of the night? Do you have pillows? And so that's a way of you grouping questions so that the examiner knows you're asking specifically about heart failure. And so like, as opposed to just shotgun approach, because in your mind, you might be like, oh, I'm nailing this, but the person marking it's like, I don't know what you're talking about. So yeah, cluster questions aren't as relevant for this. I guess the main presenting complaint would be hematuria, which would be for the cancers, and the rest would be mainly on investigations, so doing dipsticks and things like that. So you won't have to worry too much about it. In regards to the exam, it's exactly the same as second year, and they can ask you to do exams. So we have to do like thyroid exam in Ireland, and so you need to know how to do that. So the best way to practice OSCE is probably not to read stuff, but to actually to do it. And so the possible stations you can get is you can get GN for sure, and that's a good PAT station, I would assume. UTI, prostate bladder cancer would be really good for OSCEs as well. And so it will be from your PBLs, so know your PBLs. I can't repeat that enough. You should have memorized them. And if you have one thing to do for the next semester, for the semester coming up, I think you have 98 days until swap back. That's how much have I got. Yeah, I got to count on my phone. It's not healthy. Yeah, you probably should be practicing for the OSCEs because it's actually worth more than your written. It's like 55% to 45%. So
It's changed.
It's changed?
50 to 50.
Okay, well, fair enough.
Still very important.
Yeah, yeah. In terms of, it's probably easy to do better in the OSCE with effort, I think. But yeah, whatever. Cool. Now, some rare buzzwords. There they are. You can copy and paste them. No worries. because I assume you already had the main ones, so I just gave you some of the rare ones. Okay, let's go back to GN. So GN, as you remember, it's a cause of chronic problems. Now, let's just take a quick second. So GN is very confusing, and a lot of kids try really hard to break it down into nephrotic and nephritic. I understand it's very important to know there is a difference between them, but you can actually pretty much get, I know this is very like a reductionist or like a very, not a great way to study medicine, but just for exams, you can get it from clinical features. You don't even need to know that much about the disease itself. If you know about like the buzzwords and the clinical features, you can get the answer. Obviously later in life, when you're in 50 or something, study hard and be good doctors and all that. But just for third year, let's just get through the exams. So if you remember from second, they used to define GN in 2 or maybe even 3 ways. So they had the anatomical, the pathological, and then the clinical definition. Who cares? No one cares anymore. All you need to know is that if they have lots of protein, it's nephrotic. If they have blood, it's nephritic. So I'll get to it. So nephrotic, the main one's proteinuria. If you look in nephritic, it says there is proteinuria as well, but it's not a big one. So nephritic is more due to inflammation and you get bleeding out. And so that's why you get hematuria. So if you have blood, think nephritic. If you have protein, go nephrotic. One way of thinking about this is I bleed. I don't know, that might help you. That's the way of remembering it. So you can get red blood cell casts because there's blood in there. And so that's another buzzword. So RBC equals nephritic. Cool, okay. I don't know if I remember this stuff, like this list, but it does help you. The main distinction is between hematuria and proteinuria. Now, on the top right, we've got something called multisclerosis. These are called fatty casts, which are also associated with nephrotic syndrome. Now, it's good to know this, but again, you will never be asked if it's like a nephrotic or nephritic disease. You'll be asked to know the difference between those. So it's helpful to know what these are. And for all means, like you've got time to study this stuff. So, oh, great. Okay, next, yeah. So GN is a spectrum. So as you can see, just quickly taking your attention, protein is in all of it, but it's really big on the side, on the ones on the right, and hematuria is on the left. Now, so it's a spectrum, but we're going to be talking about, first we talk about nephrotic. So remember, nephrotic, O, protein, I, bleed. That's all. If you can take that away, you've done pretty well. Now understand that when I got taught renal and people taught GN, it was just like a set of words, and I was trying really hard to remember, is this one in nephrotic? Is this one in nephritic? I mean, it's good if you can do that, but it doesn't really help you out too much. So what you probably need to know is the actual diseases themselves. So let's go through nephrotic syndrome. So firstly, minimal change disease. Like it says, there's not much going on. It happens in childhood. Just know that. So young children are likely to get minimal change disease. You can get effacement of the food process of the podocytes. Now, I remember you're probably like, oh man, I forgot what that is again. Yeah, as long as you remember that there are effacement of the foot podocytes, you'll be fine. But if I back up, no, actually, no, don't worry about it. There's no point getting to it. So with minimal change, the way you treat it, and so mainly in these questions, know the clinical features and then how to treat it. It's you chuck them on the roids. The answer to most of that is you put them on roids because usually it suppresses the inflammation, so it's going to reduce their problems. Now, there's something called focal segmental glomerulosclerosis. That's the next disease, and it's annoying because it's progression. If you look, it also has effacement of the foot process of the podocytes, but it also has something called segmental sclerosis, and that's the differentiating factor. So that's the one that helps you pick between them. Basically, focal segmental means that only parts are being sclerosed, and it's not a global problem. That's pretty much all you need to know. This one you treat with immunosuppressants. Membranous GN, so this one has a lot of buzzwords. It's like with a lot of infectious diseases. Gold, don't know why. I don't know which drugs have gold in them. There's probably some. But the buzzword is GBM thickening and spikes in silver stain. So the basement membrane gets thicker. So membranous GN, G means thickening of that. So I'm going to try to help you try to remember these. Okay, so again, treatment is with steroids. Diabetic nephropathy. So again, a lot of these buzzwords are path related. You want to be treating it to basically like they're diabetic, essentially. So you go for the one you're supposed to go to is ACE inhibitor. or if they're allergic, go to ARB, because sometimes they will give you things like that. Now you just need to watch out, because sometimes they'll be already on an NSAID and aspirin, and so you got to watch out for the triple whammy. Cool. Amyloid. Yeah, so amyloid is basically a problem with all your organs where you just get deposits of protein, and so you get waxy appearance of your organs. And the kidney is actually one of the first ones to go, and so if you catch it pretty quick, it's good. I'm sure you've heard of this buzzword before. Some of you, okay, sure. Apple green birefringence on a Congo red stain polarized light. Just know that. Why would you need to know that? I have no idea, but you do. Cool. Okay, so that's nephrotic syndrome again. So let's just cover it. So minimal changes in children. Focal segmental had severe sclerosis, membranous nephropathy, thickening of the membrane. Diabetic nephropathy, you had some, I didn't say it, but you had some Kinnelson-Wilson nodules. And amyloid was when you had waxy organs with that Congo red. Okay, nephritic. IgA, post-infectious anti-G reaction. This is, yeah, we'll just go through it. So IgA. Now, this is really important. Now, IgA, as the name suggests, is related to infection. And so usually what will happen is they have an OT, and then 1 to 2 days later, note the time difference, they'll have renal problems. And you can get Coke-colored urine, and it's common in Asians. They might even give you all the buzzwords at once. The problem is, post-infected GN can also have the same things as Coke-colored urine, but it's usually 2 to 6 weeks later. So the main difference is if it's 2 days, it's IgA. If it's 2 weeks, it's post-infected. Know that difference, and then you'll be fine. And there's another buzzword about starry sky. Cool. Anti-GBM. You may have heard about this, and with Goodpasture syndrome, the main difference is if it's in the kidneys alone, it's anti-GBM. If it has lung involvement, it's Goodpasture. So that's why I remember how I asked you with the OSCE to think about other systems, like asking about nosebleeds and coughing up blood. That's important because GN can be very systemic. Lastly, we've got these group of GNs, which are related to the vasculitides, and so we'll go through them. So Wegener's, which we don't call it that anymore. So we call it GPA, or one of the main things I didn't put this in the slide, but if they have sinusitis and epistaxis, you go for this one. Yep. So just, you guys write it down and then just pass it on, or don't. I mean, be nice. Yeah. That's one of the ways you can distinguish it. This one also has hemoptysis. Sorry, I got a summary slide later. There we go. And there's the management. So most of the time, yes, we got steroids to treat it. So for most of them, you will treat GN with steroids. So it makes it a really easy set of conditions to learn about. All you need to know is the clinical features, and the treatment's pretty much the same. And the last one's HSP, sorry, which is, you probably might even get this picture. So you get these little, like, it's related to blood stuff. So you're going to get a rash of little petechiae. And that's pretty much it. Oh, no, it's not. Sorry. We've got mixed GN. So in the middle, we had some in the middle, which are both, you get the blood and the protein and everything. We've got something called membranoproliferative. Tram tracking is the buzzword that you need to know. So basically, yeah, your basal membrane is doubling up. And so that's why you get, like, it looks like tram tracks. Lupus, you guys know what lupus is. I don't need to cover that. Done. Sweet. Okay. That's quick. How do I switch?
So for those of you at home, the links to these papers are online on the Facebook group as well as the library site.
Sweet. Oh, so they can't see them? Oh, they can? Oh, okay, cool. Awesome. So we're just going to go through some of these. Oh, nice. Okay. Some of these questions, just the renal ones. And I'm going to give you 30 seconds to answer each one, and I'm going to go through it. So some of you may have done this before. I'm sorry. Awesome. Ready? Do you guys have... I want you to actually write it down because we'll practice thinking. Go. For this one, I want the disease as well. So you got 5 seconds left. Cool. Write something down. This guy looks really worried. Look at his face. Wow. Sorry, what's your name?
I don't know.
You don't know your name? Doesn't want it to be recorded. Okay. Okay, next one. Cool. Yep, next one. I'll give you 30 seconds. So we go through it. It's not like I'll just leave. All right, this one's pretty tough, I admit. These are the last ones. Okay. Awesome. Yep. Okay, we're going to go through this one before we do the other one. Cool. Okay, so I'm going to do this. I'll just go through it. So you've got this question, lots of options. It looks really scary sometimes because they're really big words and like, it's like, why does it go up to L? So many. Anyway, so how do we do this? We go through the question. We get 70-year-old woman presents significant hypertension. Okay, that's important. Rising creatinine. Yep. She gives a one history of cold fingers. Oh, that's weird. And a 9-month history of lethargy, weight loss, swelling, and stiffness of the fingers. Okay, dysphagia and shortness of breath. Okay, that doesn't seem like it fits in with a lot of the renal stuff we've been doing today. On further exam, she has thick and tight skin, especially on the fingers. So it seems like they're really focusing on this part. So I guess that's going to help us get the clue. And urinalysis shows plus proteins and some blood. So again, I mean, we'll get to the answer. And positive ANA. So now we know that it's something like something else is going on. It's not what we were talking about, like, you know, like blockages and things like that. So can we just get an idea? What did you get? Okay, pred. Yep. Why'd you go pred? Sure. Yeah. Okay. Anyone else? Afnan? Yeah. Why? Yeah. Yeah. Okay. So what's going on is do you guys know what scleroderma is? Does anyone not know what scleroderma is? You can say that. That's perfect. You don't. Yeah. So if you see it in the hospital, it's basically someone who has like their fingers look like plastic, like they're not even a real person. They're really tight and shiny. And what is this is a problem where you can have systemic and diffuse. Now, because this patient's got dysphagia and tightness of fingers, it's not just scleroderma. They've got other things going on. And what they're doing is they're having a renal crisis of scleroderma, basically. And so that's why the answer actually is ACE inhibitor. I'm really sorry we started off with this one. I know I said the questions were kind of easy after you know it. It's obviously not true. But this is a tough one. I feel like this guy, how did you know the answer? Because you were like, scleroderma? So did he tell you? No, you knew that. You just knew the answer. Wow. Okay. Good job, man. Okay. I'm really impressed. I had to check that twice. Okay. This guy should be teaching it. Anyway. Okay. Next question. Let's hope we got this one right. Steph, what did you put down for this? Oh, no worries. Okay. Just read the last line. Oh, no. Sorry.
I didn't get to read the last line.
Yeah.
So nothing.
Got it. Yeah.
So I'm assuming it's probably.
Yeah. Which one? That's correct. So remember how I said sometimes they'll just give you the answer? Like they will. So you don't have to worry too much. And let's face it, how much study would you have to do to get the first one right? Like so much study. Is it even worth it? Who knows? Like let's be honest, you got like a 1 in like, I don't know, 12 chance of guessing it anyway. You probably rule some off. Anyway, next one. This one was a bit tough. So this is one of the GN questions. This guy. Yeah.
This was one of the vasculitis ones.
Yeah.
One of them was sinusitis and kidney.
Yeah, yeah.
Hemoptysis and kidney, so she's got both. I think pastures is the common number.
That's the other one. Sorry. That's weakness or GPA. This question comes up. Sorry, what was that? Yeah. This question comes up in this paper and the other one. It shows how small the bank of renal questions are. So, yeah, I just guess know that. Okay, cool. Now this one is, again, sorry. I was looking at this paper and I was like, man, I'm screwed. Giving this lecture, like I didn't know a lot of these ones. So Anuj gave me the answers and so I was able to figure some of them out. But this one's tough. Let's just put ourselves out in misery. Did anyone? You seem quite smart. Yeah. What did you put for this? Do you want to take a stab or what's your thinking process? Like how do you solve these problems? So 1 day history of right flank pain. Okay, macroscope. She's got a past history. Why are they giving us the history? It's kind of weird. So that obviously means it's related. Afebrile, no stones. Yeah.
Like kidneys, obviously hematuria, SLA, so it's autoimmune.
Yeah. Yeah, no worries. If the answer is renal vein thrombosis because it's associated with SLE and antiphospholipid. Again, I just have to tell you that's the answer and you just have to remember it. All right, the next one. No, we're not up to that question yet. Yeah, it's up on the thing. Okay, she's got a history of weight loss. Whenever you see that, you think cancer. Yeah? Yeah, it's cancer. So she's got weight loss and she also has cancer. So it's just more cancer. Okay, now remember how I said they borrow questions from other specialties? So we've only had, in this paper, there's only like 2 questions on GN. The rest have been like on rheum, like immunologic. And these are like renal ID, but anyway. Now there's only 2 antibiotics on this list. So before we answer the question, I just want to, because I've always wondered this, like a bit of game theory. If you didn't know an answer in the AMQ, how many people here would just pick both the same so they at least get one right? Would anyone do that? Yeah, I would do that. You would do it? Okay. The rest of you would actually guess both and try to get it right? Okay. Fair enough. You do both?
So in this case, you just rule out everything
You
isn't negative.
should have one and then you get the other one.
Yeah. If you, yeah, sure. If you're
Yeah, so it's actually going to say game theory.
Yeah.
And then they go for the same. Yeah, you're right.
right, exactly. Yeah. But what if you didn't know the answer? If you had no knowledge? But like my friends are like, no, you shouldn't do that. I was like, I don't think that's right. Anyway, so they probably also study harder and actually just know the answer. Anyway, so there's two, and unfortunately you need to know what group they belong to. So why don't we just try and answer the question without getting the group and see if we can do it. So Gina, do you know what it is? Yeah. Yeah, they're going for Kef. So do you know which one that would fit into?
Kef's.
Yeah, go for it. Yeah.
Kef's a beta-lactam because it's a penicillin type, right? So kefalexin is it stops what's it called? Like penicillin binding protein.
Yeah.
So Kef stops PGP, and so that's a beta-lactam.
That's right.
And kefalexin is a third gen cephalosporin. Also used as full-spectrum negative. Yeah. Wait.
Kefalexin is first gen.
Kefalexin, what's third gen?
Cephalosporin. Yeah.
Kefalexin first gen, sorry. Okay.
So you nailed it, and then you got like 1 bit wrong, and then everyone's like, isn't that true? Like you're in hospital, you get everything right, and then you get one wrong, and the doctor's like, oh no. You're like, I tried so hard. Anyway, cool. Okay, so given that the first one's beta-lactam, what's the next one? What if it's also beta-lactam? Ooh. Nah, it's not. So do you know what the actual drug is that we're talking about? So resistant bacteria, what bacteria are you thinking about? Well, like what's the big, yeah, pretty much. And so that's a glycopeptide. Done. Okay, that was the first one. This next one is a bit easier, and it will be better for teaching in regards to how we go through questions. Okay, do you guys need more time? I feel like you probably didn't have enough time. Yeah? No? Yes? Okay. I'll give you 33 seconds. No. No, I'll give you a minute per question. It just means we have to stay here a bit longer. That's all right. You guys got nothing to do, right? All right, and go. You got it? Oh, I guess we move on.
Yeah.
Which one? Purple? They got apple Skittles in it. Seems like everyone's got it, so. All right, we're just going to skip this one because it's the same one. Actually, technically no. But. Yep, okay. Let's move on. You're good? Yep. No, this one's a bit tough. Last one. Yep. All right. Well, cool. Ready? Sweet. All right. How'd you feel about that one? Better? I think it's way better. Yeah. Yep. First one. Okay. Yeah. Why was that? Sorry.
Because she's got fevers, so she
Yeah.
infection. She's got severe pain, cloudy urine.
You're thinking this is some type of UTI,
Yeah.
and you saw that she had pain. Yeah. Basically, they didn't want to say she. Yeah. They just gave you like an anatomical location of her pain, just so they didn't have to say back pain. So yeah, that's just pyelonephritis, just that definition. Cool. Okay, I highlighted this. Hopefully you got it. Sorry. Gil, yeah. Did you have an idea? That's the two options. Yeah. Which one do you think?
I think IgA was the one that was two.
Yeah, that's right. So see how they gave you all this information? You didn't need it. Like they like told you about the dipstick and the blood and the protein, and some people get really caught up when you're answering these questions. And so this is my advice to you, I guess, to take away from this lecture is when you get the GN question, don't freak out. Like often the protein in the hematry doesn't really help you too much. What helped you was it was 2-day history, and then you should be able to figure it out. So often with these questions, like you're trying really hard to read everything, which you should because you have time in the paper, and you should just highlight key points. And often they'll give you the information without having to look at the investigations for. So you don't need to really look at the dipstick too much, but just do it anyway. This one, it's basically the same thing, it's just a different name. So, yep. Do you want to take the next one as well? Because this one is a bit hard, I admit. This is a bit tough. Okay, so basically she's got, do you have an idea of what's going on in terms of the pathology? Yeah, it's reflux. So that explains why she has the UTIs, right? Because she's not urinating as much, she's not voiding, and so she's got infection. Well, good job. Yeah. So, sorry?
We did that in yeah.
Oh, really? You had this question?
No, no, right.
No one, what? Really? Okay. Well, now you will. Why did you pick hypertensive?
We haven't done renal yet.
Fair enough. Well, you haven't done renal yet. Oh, okay. Have you done renal now? Oh, really? Oh, sorry. I just assumed you guys had all done renal. Okay. I guess, yeah, you should probably read the slides. Yeah. Yeah. All right, guys, almost done. Cool. So, what do you reckon? Yep. Why is it not pyelonephritis? Still in the answer, man. Yeah. No, you're right. So tender it's lower than higher up. So it's UTI. So like a cystitis, something like that. Cool. Has everything. She's sexually active, female. She's got all these symptoms. What? Okay. Yeah, it's a risk factor. lastly, I think this is the last question. Nope, it's not. Okay. Okay, I'm just gonna tell you the answer for this one's intravenous albumin infusion. Did anyone get that? Was it in the formative?
But look at the element, 18.
Oh, okay.
And it's gonna say it's yeah.
It just fair enough. Oh, did you have this?
Yeah, I think yeah.
Oh, cool. Awesome. Yep. It's just basically the person, he's got low albumin, so you just give them albumin.
And it's gonna say this as well.
Yeah. Cool. Okay, last one. So again, half an hour. What do you reckon?
That's really the same concept.
It's the same thing. Yeah. So why with GN, if you know a few things, you know everything. And why is that? Because 2 weeks, yeah? So again, you can find out, oh, it's red bell class, that means it's nephritic. Which ones are the nephritic disease? You try to remember in your head, or you could just remember 2 weeks after infections, post-infectious. Cool, okay, sweet. That's renal done. If you have any questions, you can ask me. Thanks. I just closed the thing. I haven't closed the actual video. The video's still going, right?
Oh, okay.
Yeah.
Oh, okay.
Yeah.
Yeah, okay. No, did you close Chrome?
No. If I close
it's
Chrome,
here,
will we lose the
it's
video
here.
or something? Or?
Yeah.
Oh, really?
Yeah. And once again, thank you to Josh for this amazing lecture. And for all of you at home, as always, good luck and Godspeed.